slight moderate encephalopathy, 2 points, and we've been through that, and 3 points was moderate to severe. And the survival depends on your scoring with a very low, as you can see, if it's 10 to 15, Charles Butte-Turcotte score of C, and a 1-year survival of 45 and a 2-year survival of 35. Now, it's principally because of these two elements that people said they needed a better quantifiable score. And for that, you had the MELD score, which was evolved by this great gastroenterologist at the Mayo Clinic called Dr. Patrick Kamath. And his issue was he based it on the creatinine level, the bilirubin level, the INR, and the sodium, and whether the patient was either on continuous venous hemodialysis or whether the patient had a formal dialysis at least twice in the past 2 weeks. So that was better in terms of being quantifiable. So just keep that in mind, guys, because again, the MELD score, the probability of mortality was fairly rigid. If we were, the MELD score of 9 or less was better at 1.9, but if you had a MELD score of 40, you had over 70% chance of not surviving. So now we come to surgery in cirrhosis and portal hypertension. So you will be situations where you do surgery and the patient has incidentally a cirrhosis and a portal hypertension, or perhaps you could actually land up in a situation where you're doing surgery for portal hypertension. So we'll discuss both. And hi guys, can you just mute your connections, please? Yeah, thanks. So the route of the liver biopsy is various techniques. You can have a percutaneous route, and that's the usual sort of biopsy where you would go through the skin and basically, if that's the liver, and that is the skin on the surface, you go in directly and you go in with a core biopsy gun or a true cut needle and you take a biopsy from there. So that route was percutaneous. But there were other techniques as well. And what are the other techniques? The other techniques was transjugular. And what was this technique? You went in through, you know that the liver had hepatic veins, and you actually went in through, let me take that as a color. That was the IVC, and these were the branches, the right, the middle, and the left hepatic veins. So you went in with a needle through the transjugular plane, and having gone through the transjugular, you found your way into the hepatic vein, right or left, and you went in and took a biopsy from here. So it's a transjugular. You had a transjugular technique of taking a biopsy as well. So you need to remember, guys, that it's not always percutaneous. But you could also take a biopsy during surgery, either at open or laparoscopic. Now, if you were taking a biopsy, the technique is, and we discussed the technique, you do a needle biopsy or a wedge. The problem of taking a wedge, guys, is that sometimes it's not really representative of the entire thing. So if you were actually doing a liver biopsy, say, sorry, it's not, I don't know what's happened to my pen. Sorry, guys, I don't know what's happened to my pen. There's something wrong with that pen. So if that's the liver, so you could take a biopsy like that. You are doing a gallbladder surgery and take a wedge of the liver. But that's not entirely representative because sometimes the fibrosis actually is more centrally displaced. So you're far better off taking a true cut biopsy because that ends up being a far more representative sampling of the entire thing. So if you were doing if you were doing even at the open surgery, if you do a true cut biopsy, you have more chances of hitting that spot. Now, the usual question is, what happens if there's bleeding? Now, that bleeding normally stops by itself. You just have to press on something and stop. But there's another very famous technique of if you've got a hole, and that's a hole with a bit going in, you have a olive mounted probe, and you put that probe in, and you put that probe into that hole, and you put in the diathermy, and then you gradually rotate this and come out. So it gets completely sealed. The blood vessels get completely sealed. So you're far better off, doing a needle biopsy, and you get a very representative sample of it. So let's consider what are the non-hepatic surgery and the assessment prior to non-hepatic surgery. Age, if it's 70 years plus, you add 3 MELD points. So, irrespective, it might be 27, you add 3, and you come to 30. Evaluation and stratification of liver disease by either the child, Turk or Tew. A had a 10%, B had a 30%, and C had an 80% mortality. And a MELD, as I told you, ascites and encephalopathy were vague terms. So MELD was a better prediction. And there's a 1 point increase is equals to 15% increase in mortality. So it's even more than a log. So a log rate causes a huge jump. But, for a MELD, if you had a 1 point increase, there's a 15% increase in mortality, guys. So the median survival for MELD is 0 to, if you had a 0 to 7 MELD points, it was 4.8, 8 to 11, 3.4, 12 to 15, 1.6 years, 16 to 20, 64 days. So you suddenly drop from the moment you cross 15, you jump into days from years. So 16, was there a question? No, there wasn't a question. Okay. 16 to 20 was 64 days. Guys, that is very important to note. So the cutoff was actually MELD 15. Below MELD 15, you're still talking of years of survival. The moment you cross 15, you're looking in terms of days. 16 to 20 was, not years, but 64 days, 2 months, thereabouts. 21 to 25 was 23 days. And if it's 26 plus, I'm afraid the mortality median survival is 14 days. So guys, that is how important a MELD or a CTP score is when you're prognosticating for the patient. Also, in evaluating for the patient, you use the ASA classification, the American Society of Anesthesia classification, and class 5 was a stronger predictor of a 7-day mortality. 4 was equal to 5.5 MELD points. So you can add to the MELD point, or you can take it independently. So there we are. Now, preoperative optimization, obviously this patient had a protein energy malnutrition. So the patient was low on albumin, so it requires low sodium supplements, 3 supplements, and branched-chain amino acids. You need to correct the coagulopathy. Clotting factors due to low vitamin K and thrombocytopenia needed to be corrected. You need to assess for hepatic encephalopathy, and one of the strongest factors which add to hepatic encephalopathy was proteins inside the GI tract. So you had to do a protein restriction, you had to do an oral antibiotics, and if you added lactulose, it changed the internal milieu of the intestine. So you had less amount of ammonia being produced. And of course, if you used oral antibiotics, you sterilized the bowels. Now, one of the common antibiotics we used to use was vancomycin, but you now have another non-absorbable antibiotics, and it's called rifaximin, which you can use to sterilize the bowel. And as a result of which, if you don't have the bacteria, you don't have the amino acids being broken down into ammonia, and you manage concomitant ascites. So, guys, what are the specific operations? There are a lot of specific operations that are often carried out. Cholecystectomy is one of them. I mean, just because you've got cirrhosis doesn't mean that you don't have gallbladder stones. And it's one of the risk factors for developing gallbladder stones. I already told you that. So cholecystolithiasis is the problem of chronic liver disease. You can have umbilical hernias. So people with ascites, if a 10 ascites, normally you have a 20% chance. So that's how high an incidence of how high is the proportion. So you have a 20% chance of umbilical hernia. This is not so common, but the commonest is an umbilical hernia. You sometimes need to do colectomies for concurrent ulcerative colitis or consider for associated diverticular disease, even mitotic lesions. Some people would even consider doing a bariatric surgery. Now, I put in a large question mark because in a patient who's not going to survive for long, it seems a bit unkind to offer him a bariatric surgery, but sometimes the metabolic syndrome, it's more than bariatric, it's a metabolic surgery that has been touted recently. Can do a cardiac procedure, you do a cardiac bypass using an octopus rather than doing a complete split and a complete lung machine. You don't do a complete, put the patient on a heart-lung machine. You would rather do a CABG using the octopus. And of course, thoracic procedures, which can sometimes need to be done. So what happens if you're doing a cholecystectomy? Got a bit of a video, I think. Yep. So that video has been run rapidly through. The principle is that you try never ever to take the posterior wall of the gallbladder out. So basically what we're doing out here is opening up, we've taken the bits, it's, sometimes the Callott's triangle is easier to dissect, but what is absolutely a killer to dissect is the posterior wall from the gallbladder bed. So you can see that having dissected out from the cystic duct and the cystic artery, the next step is usually to open up the gallbladder, suck out all the stones and the bile. If you're fortunate, you don't have multiple stones. So at the end of it, really, you have the posterior wall lying back. You can see the posterior wall there. And that's the thing that is recommended. Unfortunately, this particular patient, the ultrasonologist gave a normal liver. That liver looks anything but normal. But that was the problem. Right. And you sometimes have an umbilical hernia. This guy actually came in with a hernia with a rupture and the omentum sticking. You can see the omentum sticking out here. So basically what you need to do is, you don't have an option, but you need to go in and do something about it. And options are, you can either do a straightforward fascial repair. You do a fascial repair, which is, stitching the fascia to each other at the umbilicus. Don't use a mesh, or you can use a mesh. Now, if you use a mesh, and I'm sure you've had that discussion, if you consider that is a rectus abdominis muscle on one side and the other side, and that's the, no, that's not right. If you consider, hold on. If you consider that to be the rectus sheath, and let's choose that color as the color of peritoneum. So if you were using a mesh, so I'm going to draw the mesh in orange, so you could repair it and have an overlay. That's an overlay. So after the repair out here, you could have it as an inlay. So that is an overlay, that is an inlay, you have a sublay, and you could have a retromuscular sublay out here. So sublay, I'm going to put in a bit of a bracket as a retromuscular, or you could have the mesh placed out here, and that is a sublay again, but a preperitoneal sublay, and you could actually have an IPOM, a complete inlay like that. So basically, these are the places you could put in a mesh. The problem with putting in a mesh out here is that if you have ascites, and sometimes you have very tense ascites, what happens is that if you have a tense ascites out here, that tends to escape around this, and you have an increased tendency for infection and a fistulous drainage of ascitic fluid. So you need to do something about protecting yourself. And the way to do it is, if you're doing an emergency surgery, is to either, if you're not doing an emergency surgery, address the ascites first and then go in for a repair. If in an emergency you have to go in for a repair, then you have an option of either doing a peritoneal venous shunt or a large volume paracentesis or a TIPS. So I've got a little algorithm which might be interesting. I've borrowed this off this paper, which was very good, an umbilical hernia in patients with liver cirrhosis. A surgical challenge came out in the World Journal of GI Surgery in 2016, and I've managed to modify that for us at CCC. So you start off with a medical management of ascites. If the ascites is controlled, you can either go in for hernia surgery, can be lap, can be open. Some people swear by lap, saying that it causes less amount of bleeding, less amount of chances of infection, which is fair enough. And if you could either do a fascial repair, either lap or open. And if you were doing a mesh repair, we just talked about an onlay, an inlay, and a sublay, and an IPOM. Sorry. But if the patient had refractory ascites, early orthotopic liver transplant, 3 to 6 months, the patient is heading for an early orthotopic liver transplant, you repair the hernia during the orthotopic liver transplant. But if you were not considering an orthotopic liver transplant, what then? You do a pre-op management, and in the pre-op management, you either go in for a large volume paracentesis or a TIPS. And if that was controlled, if the patient had an ascites which was controlled, then you had a hernia repair like you had for a controlled ascites. So either a fascial or a mesh repair. Now, what happens if you had a refractory ascites? I mean, completely resistant to everything, and this patient wasn't a patient for orthotopic liver transplant. Then you had no other option. Preferred management is don't go in for hernia surgery because there's too much of complications. But it's all right to say that our ascites is partially controlled or in emergency, like this chap out here. So you either do a repair and then you put in a post-operative large volume paracentesis, or you put in a peritoneal venous shunts, or you do a TIPS. Now, if I were to go back out here, you will notice that this guy out here actually has a little scar out here. You can see that this patient actually had a large volume paracentesis. Even then, he managed to develop this. So the problem was, if you repair this, it's already the momentum is sticking out here. So it is prone to infection. And, sometimes you put in a mesh that gets infected, then you've compounded the problem. But what you can do is you can do a repair. If you can guarantee that there's no chance of an infection, put in a peritoneal venous shunts. And the peritoneal venous shunts are, peritoneal venous shunts. So you can either put in a Levine shunt. That's the thing which lies below the fascia. That's a perforated one that goes into the abdomen, and another tube which actually goes out into the subclavian or the jugular vein. So that's the peritoneal, that's the Levine shunt. You could also do something, could have something called a Denver shunt. And then the Denver shunt you had almost everything except that you actually had a tube, a perforated tube, and if that's the costal margin, the compartment was situated out here. That's a valve with a compartment with a valve, and that is the other part that heads towards the vein. So this was the Denver shunt. The Denver shunt had an advantage in that the patient was actually encouraged to press that and cause the peritoneal fluid from getting absorbed. It encouraged flow into the veins on top. So that is the Denver shunt. So these are the two shunts that are in vogue, and so this is one of the options that you can do if you have a patient like that. You can see that this patient actually had a strapping put on to prevent the momentum coming through. But obviously he's in a bit of a sad situation. Right, so that is your umbilical hernia and cirrhosis with ascites. You guys want to take a screenshot of that, you can go ahead and take a screenshot of this.
Sir,
Yeah.
When we say facial repair, it is like which layer do we suture? Like
just that umbilicus, you just have one fascia, isn't it? So you just repair one fascia to the other. Let's go back to this. I can draw out here. I can't draw out here. If think about it, guys, if you say, let me choose that color to show fascia. So basically, what it is that you have the linea alba forming out here, isn't it? And that is the umbilicus. At the umbilicus, everything is fused. Okay? So you had a hernia out here, and sometimes it's a fairly largish hernia. So what you do now is you take the hernia off, and then you stitch that into this end. Hang on, let me just get that. You stitch from here to there. Interrupted sutures. So that's a fascial repair. You remember there was a overlap repair that we used to do that was given up because fresh tissue edges seal. If you do an overlap, if you do an overlap, let me just choose the color correctly. If you do an overlap, say let's suppose you have you're doing an overlap. If you're doing an overlap and you repair this out here and that stitched out here, that edge is not fresh. So fresh edge doesn't come to fresh edge. That has a higher incidence of recurrence. That used to be touted as a wonderful operation. You'll hear that operation being described in old textbooks where you actually had an overlap of the hernia. You had the top fascia came over and was stitched to the anterior surface, and the bottom layer was stitched to the bottom end of this surface, but that had a higher incidence of recurrence. So a fascial repair actually means fascia to fascia out here, okay? Because there's only one fascia at the umbilicus, isn't it?
Okay, sir. Thank you.
Right. Unfortunately, this chat... Yeah, sure. Tell me.
Sir, even if we are doing all the hernia repairs, but overall prognosis is not good. Even if we are doing it, it's not going to well, right?
Yeah, but then if you have a patient who's coming with an emergency like this out here, what are you going to do?
Yes, sir.
You have to do something for the patient. So the best to do is to repair the hernia and either give the patient large volume. One of the options that we've often done is to put in a drain. Okay, put in a clip on that drain. Don't let it drain continuously, but drain large bits every day under cover of sulfur albumin. But then sulfur albumin is also expensive. The other option is to put in a peritoneal venous shunt. And finally, if you have the facilities, do a TIPS. There are three options available. we did something silly, but for this patient, we did something extremely silly, but that was a trial. And I don't want to show you that because though we did about 4 or 5 patients of that, it wasn't very successful. So we gave it up as a trial. But if you're interested, are you guys interested?
Yes, sir.
Yes, sir.
We did that. And what we did was, think of that, the saphenous vein, it has a valve, so it doesn't flow back. So you cut it out here, turned it over and did a peritoneosaphenous shunt. So this is what we did for this particular patient, because he was part of a trial and we were trying to do something for these poor patients. I mean, this was a tea stall owner and he couldn't afford a shunt. He couldn't afford the albumin that you needed for a large volume aspiration, but he could afford his, local drink, toddy, and he just wouldn't give it up. So we tried, this is something that we tried, but guys, what happened actually? We cut the saphenous vein, make sure that the vein doesn't bleed backwards. There's no back bleed, which means that the valve out here was intact. And then we brought it up and stitched it to the peritoneum venous shunt. But you can well imagine it's a very poor substitute. It's at the groin, it can get blocked and kinked very easily. And more importantly was what happened to this chap is that we actually lost him to circulatory overload. So, we tried 3 or 4 and then we gave it up as a bad job. So don't even mention it anywhere. So there we are, surgical. Sorry?
Excuse me, sir, just 1 minute.
Yeah.
So the previous slide, the one where you showed following the large volume paracentesis or tips, sir.
Yes.
Can you just go back to that slide?
Just a sec. We need to go back. Yep, this one. This one?
Yes, sir. Yes, sir. The one which is ascites partially controlled or emergency.
Yep.
That comes after, because we have already, where does this follow exactly?
See, you've done a large volume paracentesis, but the ascites hasn't been controlled. And this patient then comes in with something like that, something with a ruptured umbilical hernia. So if with a ruptured umbilical hernia, you have to do something about this patient, isn't it? You can't leave him there. This group is all right. Refractory ascites with an umbilical hernia with no emergency, you keep on conservative management. You say this is too poor a risk. Ideally, if this chap, this man with this situation was having a bottle of drink a day. I mean, he's not a person for orthotopic liver transplant. He's not a controlled alcoholic. He was a hopeless alcoholic. But you need to do something about them. And if you repair that hernia and just leave him there, it's going to leak. So you need to do something to get that ascites out. And the options are a large volume paracentesis. But if you're giving large volume paracentesis, you need salt-pure albumin. And salt-pure albumin is expensive. Okay? You need to either put in a peritoneovenous shunt. The shunts are expensive, and he couldn't afford that. He obviously couldn't afford a tips. So the option really for this, if you're doing an emergency, are 3. The 3 options are you either go in for the easiest and the simplest is a large volume paracentesis. Okay, that's number 1. Number 2 is a peritoneovenous shunt. And number 3 is a tips. The 3 options that you have in an emergency.
So
get it?
These 3 options will also go the person who's already undergone a large volume paracentesis of tips, because you've written there that if they have undergone a large volume paracentesis tips, and if that fails, we repeat the same thing, sir.
Yes, you repeat the same thing, because what happens is, that's you're basically clutching at straws out here, isn't it? You're basically clutching at straws. So you've done a large volume paracentesis. If you've done a TIPS, normally your ascites is controlled. You've done a large volume paracentesis, but the patient comes back with ascites once again. He goes out and goes on an alcoholic binge and comes back with the, like this chap. I mean, basically, he was controlled with for his ascites. Then he goes off and says he's fine now and he starts drinking again. So ascites is partially controlled or in an emergency. Then you have an option. If you've already haven't done TIPS, then you do a TIPS. Okay. You don't do a re-TIPS, okay? So if you've done a TIPS, normally it goes into this group. The ascites is controlled or patient goes into refractory ascites despite a TIPS. Now, you've done a TIPS, this patient is an alcoholic, not responding to your treatment, you just treat the patient with conservative management, because ideally, if you could get him off alcohol, that is the treatment that you would do, orthotopic liver transplant, isn't it?
Yes, sir. Thank you, sir.
Get it? So this is one of those situations which is a difficult, which is why I've colored this separately. That's a separate group altogether. These are for patients, those patients who are not considered for orthotopic liver transplant, largely because they haven't managed to come off alcohol and then they land up in an emergency.
Yes, thank you, sir. And so one last question, sir.
Yeah.
So why, I did not hear before, sir, why are gallstones and pancreatitis associated with this? And secondly, why are we doing it with colectomy and colectomy? Yes.
Suppose you have, I mean, these are operations that have been done. They are operations that are done in the presence of chronic liver disease. Gallbladder stones and pancreatitis have a higher incidence in people who are cirrhotic. So that goes out of the thing. You often have, you think about it, this patient is a smoker, he drinks alcohol. So the etiological conditions are the same. So this patient can have pancreatitis from his alcohol, and because of his smoking and alcohol, is more prone to mitotic lesions, cancer of the colon. But cancer of the colon operation is a really major operation because you have plenty of portal systemic anastomosis around the colon. So it's not a very easy operation. Cardiac operations, patient is a smoker, drinks alcohol, develops a coronary artery disease. So what do? You don't put these patients because of the large volume swings. One of the major problems of ascites, doing surgery and ascites, is huge volume swings. It's impossible to keep a check on that. So you would not put the patient on a heart-lung machine. If you're doing a coronary, a CABG, you would prefer putting in an octopus and doing it without the patient on a heart-lung machine. Okay? Thoracic procedures, think about it. What is the way out? You've got a liver which stops the IVC bringing in the blood. So all the blood goes into the azygos and the hemiazygos veins. And think about it, hemiazygos and azygos veins have intercostal veins draining into them. Think about a thoracotomy, you're doing a thoracotomy and you have a torrential bleed when you put in an incision into the chest. Get it?
Yes, sir.
Okay, right. Right, surgery for portal hypertension ascites. Portal hypertension, the following are the surgery possible. You do a non-shunt surgery, which is devascularization. You have a shunt surgery, which could be a selective shunt and a non-selective shunt. And of course, you have an orthotopic liver transplant, which could be a living donor transplant or a deceased donor liver transplant. Okay, so these are the options of treatment, surgical options possible for a portal hypertension. Now, I'm going to talk a bit about the anatomy of a portal hypertension. You have the splenic vein and the portal vein hugely distended. You also have a drainage into the azygos and the hemiazygos system. I think the next one is better. Yeah, so that becomes larger as well. So as a result of which, now these are the azygos and the hemiazygos system take the circulation away. And that is the picture, we did that picture, didn't we? You remember this picture, all of you?
Yes, sir.
So you remember that the structures that are not easily identified, and I think you guys are very good, and I don't want you to miss that, is that is the coronary vein. You can see the coronary vein out here. And you can see the azygos vein out here. Okay, that is number 9, and this one is the coronary vein. Right. So remember, guys, I mean, you're very good with CT scans, so I've just borrowed that from Radiopedia so that you can have a look. Now, if I'm going to go back into the anatomy of the hypertension completely, as I said, the portal vein and the pharynx and the splenic vein are large, but you also have the coronary vein out here, and you have the short gastrics out here. Now, think about it. Let's suppose this patient comes in with torrential bleeding. So what is the devascularization procedure you could do? You could actually do a complete devascularization of that. So that's a left gastric arcade. You could do a devascularization of this part. But in doing this part, sometimes you actually need to take the spleen out as well. Okay. And in addition, you also have perforators, and the perforators are situated where the perforators are situated. Yeah, out here. These are the perforators. So you need to take essentially that bit out. You need to take that bit out, and you need to take that bit out. Right. So, and you need to take the spleen out. Once you do that, there was an operation called the Hassab's operation. Hassab's operation. Now, when you do that, people didn't realize that the patients actually had a very, very, very rich submucosal plexus, and that is the one that gives you varices. So you had a submucosal plexus out here. So that kept on bleeding sometimes, guys. So Seguera did something. Seguera did a thoracic approach. He took 15 centimeters of devascularization out here. He did a complete revasc out here, like we've done, along the lesser curve and the greater curve, saving the epiploids so that the blood supply was patent. But in addition, he borrowed something from another surgeon, and that surgery was Boehringer-Kreil's operation. And what Seguera did, you don't need to remember what Boehringer-Kreil was, but what Seguera, S-U-G-I-U-R-A, Seguera. What Seguera did was he cut the anterior part of the muscle. So effectively, if I were to show you 3 layers, that's the muscle. Think about that as the esophagus muscle. That was the mucosa. So what Seguera did was he cut the complete the anterior part of the muscle. Yeah, he cut the anterior part of the muscle. Then he cut the entire mucosa on all sides. Then he stitched up the mucosa completely and followed up by stitching the anterior muscular wall. So he didn't cut the entire muscle of the esophagus. He just cut the anterior part of the muscle, and he did a complete mucosal transection and stitched it up. The reason for that was that he quite rightly realized from Boehringer-Kreil that the major culprit was not just the perforators, but also that leash of blood vessels, the submucosal blood vessels. Right, okay. So that was Seguera's operation. So, guys, I mean, if we go on and show you, I've got some diagrams. So, from Blumgard, that's the Hassab's operation. And what he did was basically remove that whole segment, including the collaterals including the vessels from the diaphragm, the phrenic vessels. Remove that. The left gastric vessels have been lifted that up. But because he's also devascularized that completely, what else was divided? Let me choose that color. There's something else that is being shown out here that's also been divided. That. Another one, that. What do you think these were? The vagi. Absolutely right. The vagi were also cut, which meant that you needed to do a pyloroplasty out here. So that is exactly what we are going to show you next. That was a complete procedure. Splenectomy, devascularization all along the fundus and the diaphragmatic surface, devascularization of that area along the left gastrix, devascularization of the lower 7 to 10 centimeters of the esophagus. If you were doing a classic CIRRHOSIS, you went into the thoracic approach and did the devascularization of the last 15 centimeters. And you also did a pyloroplasty because your vagus was also damaged, and you did a transection of the mucosa of the esophagus and stitched it up. So that was the CIRRHOSIS operation. Then there were some modifications that happened, and the modification is what I'm going to show you. So the first step was the spleen was removed, gave you a lot more of space. You did a complete devascularization of this bit out here. So let's choose red, and we are going to do, as we are going to do a devascularization, let's just choose red. So we've done a devascularization of that entire process. And we've done a devascularization of that process, leaving the anterior and posterior nerves of lateral jet. And in the next step, what we've done is, before we do the devascularization of the esophagus, what is done is that you remove, so we remove that, and we move the vagus to the side. So once you move the vagus, both the vagus, anterior and posterior vagus, to the side, it meant that you could now save the nerve to lateral jet, so you needn't do a pyloroplasty, and you did a gastrotomy. And in doing a gastrotomy, you now use this wonderful circular stapler. You put in the circular stapler and fired it across. So your whole purpose of doing a mucosal resection was taken care of. You know, the CIRRHOSIS mucosal resection was not just a mucosal resection, you did a complete transection of the esophagus. So guys, that was the modified CIRRHOSIS operation. Right. So that was a modified CIRRHOSIS operation, and that was from Bloomgart. And this is the result of the devascularization. Hassab had an operative mortality of 12.4%. A CIRRHOSIS had an 8.5, and a modified CIRRHOSIS had a 7.1. But the 5-year survival, as you can see, for a Hassab was 73 and 85. CIRRHOSIS was 32 to 75, but for a modified CIRRHOSIS, a very abysmal 23 to 72% of a 5-year survival. And there we are. Right, now we come to shunt surgery, which can be non-selective and selective. So what is the difference? Non-selective. Non-selective means that the large amount of blood flow is shifted out from going into the liver into the systemic circulation. So let's just see what we can do. We got a liver out here, which is, honestly don't know why my pen is acting up. Anyway, no, it's not right. So that is the liver. That's cirrhotic. So if now you did a shunt, which effectively, that was a portal vein which is completely blocked because of the cirrhosis. So you did a shunt where this entire flow goes into the systemic circulation. So that became a non-selective shunt. So you weren't trying to force some blood through the liver. So that became a non-selective shunt. If, however, you did some procedure by which some amount of blood flow was going through, and a bit out, so that you had both an advantage of avoiding hepatic. The problem of doing this is that you had a very high incidence of hepatic encephalopathy, because every bit you had nothing going through the liver. So the liver mitochondria, which normally did a Krebs cycle to transfer ammonia into urea, wasn't there. So you had a very high amount of ammonia in the tissues, as a result of which people had a very high incidence of encephalopathy. Whereas in a selective shunt, you had some bit going through, so you had a portion of this NH3 being transferred into urea through the Krebs cycle in the hepatocytes. Right. So what are the non-selective? You can have a portocable shunt, a mesenteric cable shunt. You have a proximal splenorenal shunt with splenectomy. It's called the DSRS. And you had a splenorenal shunt without splenectomy. So I'm going to go through some of these in a bit of detail, because I think it's important you guys have a fair amount. Shunt surgery, and Dr. Shujoy Paul of All India Institute had a beautiful article, and the selective shunts he described in the Indian Journal of Surgery was the distal splenorenal shunt, the surface small diameter interposition 8 millimeter H graft, and the Inoguchi's coronary cable shunt. Now we'll draw it out, don't worry, it sounds big names, but we'll draw out everything for you. Right. Now, in a shunt, what are the main players? Shunt surgery, main players, portal pre-block. You have the splenic vein, you have the portal vein, and you have the superior mesenteric vein. What are the shunt surgery main players? No block. So you have, the coronary, I forgot about the coronary vein. Yes, of course, you have the coronary vein as a pre-block. In the shunt surgery main players, no block is the IVC and the left renal vein. So these were the structures that you could use. Now, let's see what is done in a proximal splenorenal shunt. So in a proximal splenorenal shunt, this is what the abdomen looks like. I've done a bit of animation. It's going to be slightly amateurish, but what the hell. So you move the spleen, you first move the colon down, you move the stomach up, you move the pancreas up slightly, and then what you do is you do a splenectomy, and post-splenectomy, you do a shunt from the splenic vein into the left renal vein. Right. Now, think about it, guys. I'm going to draw now. I'm going to draw now the flow. The flow is, a bit iffy from going up there. It can't go out there because of the cirrhosis. So if you've got a bypass out here, think of what happens. The entire flow now goes through that way. So if the entire flow is going through that way, including the flow that comes down the coronary vein, and that comes in and also flows in out that way. So you've got the entire thing coming out here. So this obviously became a non-selective shunt. So PSRS is a non-selective shunt. Okay? Is that clear? Because you can appreciate that the entire flow is going through out there. Now we are going to talk about the DSRS, distal splenorenal shunt. Proximal means it's proximal to the spleen. Distal means it's away from the spleen. And in a distal splenorenal shunt, the primary part of the operation is same. Colon moved down, stomach moved up, pancreas moved up. And now what you do is, don't remove the spleen, and you do a shunt. You take this off. You cut the splenic vein out here. Now let me just cut the splenic vein. So you cut the splenic vein there. Oops. Just a sec. I don't know what's happened to my pen, guys. Sorry. So you cut the splenic vein out there, and you transfer that amount out there. Now that became we haven't done one step. but you need to tell me that. This became a selective shunt because some bit of blood is going through into the liver. But let me find out what goes into the liver. Now, obviously, the flow from here can't come in, so it has to go towards the liver. But there's another escape route. Another escape route is that it now trickles into the coronary vein, and through the coronary vein, it goes through into the splenic circulation, then goes in and then comes out. Okay, so the last step of a DSRS is, and that is something that if you don't do, it still becomes a non-selective, is that you have to cut the coronary vein. So now if you've cut the coronary vein, what happens is, you cut the coronary vein, now a bit of the flow that is coming up from here, flows in out here. Flow that through the esophagus, all that is around the esophagus comes via the splenic into this area and comes into the splenic vein. But think of the part which is carried out by the superior SMV, superior mesenteric vein. It has to go through the liver. It has to go through the liver because you've already, don't forget, you've cut the coronary vein. So it can't escape the coronary vein. So therefore, in a distal splenorenal shunt, you expose it, take up the pancreas, take all the, you divide all the branches to the splenic vein, and you cut the splenic vein out here, and you do an anastomosis end to side, splenic vein to the left renal vein. So it's distal to the spleen, therefore distal splenorenal shunt, whereas the other one was proximal to the spleen, so it's a proximal renal shunt. The moment you cut the coronary vein, it becomes a selective procedure. If you don't cut the coronary vein, it still becomes a non-selective procedure. Do you appreciate that? I'm going to wait for a little while.
Yes, sir.
Okay, right. Great. Which is why I've drawn this rather ridiculous animation. Sorry about the guys. Okay, right. So the result of DSRS was the operative mortality was 4.7%, and the morbidity of 41.7%, with a 1-year survival of 90.1%, which is very good. A recurrent variceal bleeding was observed only in 2.4%, because don't forget all the veins from around the cardioesophageal junction drained into the left renal vein. Hepatic encephalopathy was only 4.8%, whereas in a PSRS it's 12.5%, and ascites in 14.6%. Overall, the DSRS shunt patency, and that was also another important thing, was 97.6%. Right. Now we need to talk about the other shunt surgery. And the other shunt surgery was, suppose we did these are basically surgeries where you would actually do a portocable shunt. So let me choose a slightly darker color. So portocable shunt there, or a mesenterico-cable shunt out here. You could also use a jump graft, which would mean you were actually putting in a graft between that and that. Sorry, no, I'm going to draw it. It shouldn't be so thick. Putting in an H, so it became an H graft. You're putting in a shunt between the mesentery and the cava. Now the result of this was the improvement in ascites was dramatic. But as you can well imagine, the huge amount of blood flow went into the portal vein. So from the portal vein into the IVC. So you had a very high incidence of hepatic encephalopathy in operations like this. So basically, this was the egg fistula that was originally described, 1983, guys. So, you know, very long ago. by a very famous man called Thomas Starzl. He was the father of liver transplantation in USA. So he started this thing, the portal cable shunt was called the ECK fistula, and he said that there was too much of a high incidence of encephalopathy. And even in animals, and he was doing it in dogs, he found that if the moment he gave them a rich protein diet, they all ran away. They ran away, became almost like mad, and they had to be put down. So the original egg had 8 dogs, of which the traditional, this is a very famous story, 7 died the moment he gave them meat to eat, and 1 ran away. So that's a famous story about egg, as in egg fistula. So Thomas Starzl did a beautiful write-up about that. But so what was the possible? You see, the type of shunt, if you did a portocable shunt, the incidence of encephalopathy was a very high 54%. A mesenterical cable shunt was 35%. But there was a very interesting thing. You remember that I told you in that paper by Shuja Paul of something called a Sarphase graph. This was the thing. If you had a diameter of shunt in millimeter, if it was 2 millimeter, you had virtually no post-shunt encephalopathy. 4, you had no patients with post-shunt encephalopathy. The moment you went up to 8 millimeter in diameter shunt, the incidence of encephalopathy was 21%. So, which is why the Sarphase group said, put in an 8 millimeter shunt. The moment you went up to 16 millimeter, the incidence of encephalopathy went up to 64%. So if you were putting in a shunt, so it was obviously better for somebody putting in a shunt to put in a smaller shunt, a smaller diameter shunt. This was better. The moment you put in a wider shunt, that was poor, because you had a 64% encephalopathy, whereas if it was only 2 millimeter, the encephalopathy was 0. But then why not use a 2 millimeter? Because the incidence of thrombosis inside that was also very high. Patency was very poor. So you didn't have any patency. So effectively, you put in a 2 millimeter shunt, work for a couple of days. Don't forget these are slow flow lesions, and you had a clot out there. So the patient had effectively not a shunt. So it blocked off completely. Therefore, the ideal size, and Sarfe was the person who did this trial out here, said that the ideal size is somewhere in between. So what he opted for was an 8 millimeter shunt, which was the higher, the incidence of thrombosis was not as high. So that became a selective shunt, part of the selective shunt. The other shunt which was described by the Japanese was the Inoguchi shunt. What they did was they cut the coronary vein and anastomosed the coronary vein to the cava. So you can well imagine this was also not a very high, this was also not a high diameter shunt. So the incidence of encephalopathy was fairly low. So this is also, so effectively Sarfe shunt was a selective shunt. You had the DSRS, which is a selective shunt, and the Inoguchi, this is Inoguchi. Inoguchi shunt of a coronary cable shunt. It was the coronary cable shunt. So these are the three. So DSRS, going in out here, Sarfe, 8 millimeter jump graft, and the Inoguchi coronary cable shunt. These are the three ones which are selective, because you still induce a fair bit of flow up the portal vein into the liver. Right.
So Sarfe is a mesenteric cable shunt, sir?
Yes, it's an 8 with an 8 millimeter diameter of shunt.
Thank you, sir.
Okay, right. So these are the 3 selective shunts. Right, so this was the hepatology graph, which says that this was a patient who had post shunt encephalopathy, and you can see this was the original table. If the diameter of shunt is 2 millimeter, the radius of the shunt is obviously half of that. The fourth part of the radius is 1, and the patient with PSC was 0 for 2, 4, 8 was 21%, and 16. The moment you came up to 16 millimeter shunts, the incidence of encephalopathy went up suddenly. You can see that jump from 8 to 16 was a very high jump, 3 times the amount of encephalopathy. There was another shunt that has been carried out. It's called the REC shunt. If you had a portal vein blockage with portal cavernoma out here, you could put in a graft and do an anastomosis from, hang on, let me just choose that color. It can't be too narrow. So you put in a graft from here to the portal vein, to the portal branch, the left portal with the portal vein. Come on. This is the portal vein to the left branch. Or you could do it to the right branch. It's easier to do it to the left branch because the left branch has a certain segment which is extrahepatic. So portal anastomosis is called the REC shunt. Portal anastomosis is called the REC shunt. This is principally for people with extrahepatic portal vein thrombosis causing portal cavernoma around that area. And sometimes you even have portal biliopathy because there are large veins situated around the common bile duct causing blockage, causing jaundice as a result of narrowing. Right. So now I'm going to give you 2 charts. These have been adapted. I've adapted them from Bloomberg. So guys, would you take a screenshot of this? Algorithm for definitive treatment. See, I mean, if you're given a OSCE session, this is something that is going to be your cheat sheet. So algorithm for definitive treatment, non-alcoholic and abstinent alcoholic cirrhosis. This is important. They have abstained from alcohol. Transplant candidates, child C, going for tips, going for banding, going for sclerotherapy to buy yourself time, then going for transplant the moment a transplant becomes available. If the patient has a child A or B with symptomatic stable disease, if the patient has good access to its the varices, you go in for banding and sclerotherapy. I would suggest now we drop sclerotherapy from our armamentarium and use banding because it's available everywhere. If it fails, it could qualify it as a progressive disease, then it goes in for transplant. If, however, a child A or B has a symptomatic stable disease but has poor access, like a gastric varix, sudden grade 1 or even sudden grade 2 intragastric varix 1 or 2, you see, it is virtually impossible to do a banding of a gastric varix. I told you why, because it is impossible to do a J maneuver and get a banding onto a gastric varix. What we normally do is inject cyanoacrylate glue. But even then, I mean, these are the sort of patients where you would consider a selective shunt. Again, the selective shunt is for you, talk about the distal splenorenal shunt for a first. And if we get pressed, talk about the surface 8 millimeter jump cable shunt or an Inokuchi coronary cable shunt. So these are the 3 selective shunts that you can talk about. Right. The second, now take a screenshot of this. Non-cirrhotic, active alcoholic, elderly with poor Karnofsky status, is compliant and has a good access. You go for banding or sclerotherapy. I've put in the sclerotherapy for form's sake. Nowadays, you would actually go in for banding. If the patient is non-compliant with poor access or has gastric varix, you classify that as also a failure. If the patient is a poor operative risk, you go in for a TIPS. Buy yourself a bit of time. If it's a patient with a good operative risk, if the patient has good ascites and a good anatomy, you're going for a selective shunt. Intractable ascites, as I told you, that non-selective shunts are wonderful for ascites. Selective shunts don't have such a good effect because you're not transferring the entire flow away from the liver, which meant that your ascites doesn't respond as good as well. So if you have an intractable ascites, you go in for a non-selective shunt and take a risk with encephalopathy. If you have a splanchnic venous thrombosis, you can go in for a devascularization of the splanchnic venous system. I've had an incident where the entire portal system was thrombosed after a Partington-Rochelle procedure. We did a Partington-Rochelle and this patient wasn't feeling all right. So we did a CT scan. We discovered that the entire portal venous system, the portal vein, the superior mesenteric, and the splenic was thrombosed. And he came in walking. So we put this up to our GI surgery group because I was really worried. And the treatment was just do an endoscopy and keep a check on him. And he was outside from my city and he keeps on coming back. Whenever I see him, I feel very scared, but he's doing all right. Right, guys. Any other questions? That's my last slide, I think. Yes.
Excuse me, sir.
Yeah, go ahead.
Sir, could you just explain DSRS once again, please?
Okay. Let's go back. Oops, no. Why am I going this way? Okay, right. So we start off by getting in everything into its place. So we move the colon down, right? Move the stomach up. So now you're accessing the lesser sac. Okay, right. Now lesser sac, the posterior part, you have the pancreas lying in. So you need to raise the pancreas because you need to access the splenic vein. Having accessed the splenic vein, now what you do is you do something. That's something I managed to forget to put in. Sorry about that, guys. But what you do is you cut that, divide the splenic vein from there. And then you do this procedure, which means you do that. You bring that portion of the splenic vein and anastomose that to the left renal vein. Now, if you leave it there, this is the important bit to realize. You still have the coronary vein. So what will happen is, think about it, guys. What will happen is that flow bumps off out here, comes in out here, gets bumped into the liver. So it finds an escape route through the left coronary, through the coronary vein, into the splenic, through the splenic, and then comes in out here. So effectively, you thought you were doing a selective surgery, but you haven't done a selective surgery. That gets the entire flow goes out throughout here. And in addition to having bleeding from a gastric varix, you also have encephalopathy. So the treatment, that the last step, and you mustn't forget that, is to cut the coronary vein. So if you cut the coronary vein, then this has no option but to go in partially to the liver. That has to be forced into the liver. That can't go there because you've already tied that off. Get it? You've tied that off, you've cut that, and you've cut that, so it can't escape there. It has to go through the liver. So now it becomes a selective shunt. Get it?
Yes, thank you, sir.
Right, okay. Right, so any other questions? The difficult topic, so I've split it up into two.
Excuse me, sir.
Yep.
Sir, what are the shunt surgeries that we do in emergency which are like less time consuming, sir?
Less time consuming, and the easiest is do a mesenteric or cable. For the uninitiated, you don't want to handle the, it's very easy to talk about the DSRS, but think about what the vessels, the collaterals that you can see come across in a DSRS. Taking the pancreas up off the splenic vein is a very, very, very stressful work in portal hypertension. Okay, so I think that the easiest shunt to do is to do the surface shunt. So in a surface shunt, what do? You do a, yeah, I've got that. So you do a shunt out here. Just make sure it's 8 millimeters. Okay, so that makes it a selective shunt. That takes the pressure off your vessels, and it's a because you see, I mean, you dissect out what you do is, the way to approach it is, okay, since we are talking about that, spend a bit of time on the approach. The approach is just like you do a right hemicolectomy. You lift this entire thing up. When you lift this entire thing up, then you see the superior mesenteric. You see the superior mesenteric vein out there, okay? And the colon is on the top. Now you've got the ileum going out there. That's the posterior part of the cecum and colon. And you've got the IVC out here. Let me choose that color. Yep. So you've got the IVC up there. So now you choose a shunt, which is a 8 millimeter shunt. Okay. You choose an 8 millimeter shunt and you put it across from here to there. The important thing is just remember that it has to be an 8 millimeter. With an 8 millimeter, you have a 24%, about a 20% chance of post shunt encephalopathy. Okay. That is one way of getting out of a difficult situation. I can appreciate why you're asking that question. So, yes. Okay. Right, guys. Yeah.
So these shunts which you are placing 2 mm, 4 mm, are these synthetic materials?
Yeah, you use synthetic materials because otherwise what you can do if you don't have a synthetic material, what you can use a harvested superior vena cava, which is approximately around 8 millimeters. Okay. Or you could use an internal jugular, but the internal jugular diameter is far larger. It's more than 8 millimeters.
Yes, thank you.
Right. If there aren't any other questions, look after yourselves. Be safe, guys. And good night.
Thank you, sir.
Thank you, sir.
Thank you. Thank you.
The recording has stopped.